Dear colleagues, welcome to this new ESMO roundtable around COVID-19. We have today a multidisciplinary panel with great panelists. My name is Philippe Aftimos. I will be the moderator today. We have Plar Garrido, who is the head of thoracic oncology at Hospital Ramon y Cajal in Madrid, Spain. We have Alberto Sobrero, head of medical oncology at Hospital San Martino in Genova, Italy. Ravindran Kanesvaran, a medical oncologist at the National Cancer Center in Singapore. Maria de Trill, who is President Emeritus of the International Psycho-Oncology Society and the Director of Psycho-Oncology in Spain. And Andreas Charalambous, the President of the European Oncology Nursing Society. We are going to cover a few questions regarding post-COVID-19 reorganization of care. And I would like to start with the first question to Dr. Sobrero. So now that the pandemic has passed, at least the acute part of it, how should we reorganize cancer care? Dr. Sobrero.
Hello. I'm sorry, there was a helicopter here at the hospital landing. Well, essentially during this emergency, we have become aware of the fact that we tend to follow our patient too closely. Partly because we want to do that, because we want to be scientific. We want to measure the disease before and after treatment, and sometimes we kind of obsessively pursue this strategy that has been taught to us through the decades. At the same time, the patient wanted this very close-up care. Now, I don't know how much it came up on our side and how much the patient were ready to accept a gross tuning of this paradigm. Because what happened during the COVID emergency, at least in my experience, was that the patients understood immediately the fact that in our decision-making process, benefit on one side and cost, meaning toxicities and inconveniences on the other side, were complicated by a third factor, that is additional toll to pay, and that was the risk of dying because of the COVID epidemics. So my experience was that they understood this, and it was a sort of ping-pong adjustment in us proposing to them not so close follow-ups, no matter whether advanced disease or adjuvant disease, or even follow-up periods after adjuvant. They immediately understood. And that was quite surprising, because I would have expected on their side not to be so ready, understandable, our decision of losing up the term of the follow-up, meaning true follow-up or visit or follow through the advanced disease or adjuvant disease. In terms of how to reorganize, simple. We should focus more profoundly on the goals of our treatment. So what comes first is whenever we can cure the person. So early diagnosis should not be lost. And that is the most crucial aspect, because that is where our system failed. There were patients still needing the primary diagnosis who had this delayed by 2-3 months. And that was something that should not be repeated. So all the follow-up visits should be delayed, no question about that. Say in the adjuvant setting, be careful about the size of the benefit that the patient may get out of the adjuvant program. number two, because if the size of the benefit is 1 to 2%, then you may get rid of it. And you may discuss with the patient and implementing the extra risk they have. And that's number two. Number three, in the advanced setting, where there are cases where you may not follow the patient so obsessively with repeated CT scans. So this is the bread and butter recipe for how to prepare us and deal with the problem in case it comes back.
Thank you, Dr. Sobrero. So all of you at your different centers all over the world had to reorganize differently. The medical societies gave some advice. Now, this question is for all the panel. Are we back to normality today, or is this a new normality? So I would like you to discuss that and explain a little bit if we've learned and some new opportunities have arisen from this pandemic, such as de-escalation of therapy, telemedicine, and other activities. Maybe we can start with Dr. Garrido.
Thank you. Yes, my answer is yes. I think we have learned a very valuable lesson from the pandemic. And one of them, at least from my point of view, is the added value of telemedicine. We had to implement these kind of tools very quickly, but now I think, at least in my environment, that this kind of relationship with patient could be very useful in some situations, for instance, for monitoring toxicity or symptom control, and it's a good way of minimizing the number of visits to the hospital that for some kind of patient could be very useful. I also wanted to highlight that we are speaking about cancer, but we know that cancer means very different situation, very different patient. It's not the same speaking about one type of tumor versus other, early stages versus late stages, ECOG 0 versus no, active treatment versus not. No. So when speaking about the way of move forward, maybe we need to take care about if we are thinking about some specific subset of patients. But in general, for instance, one of the most valuable experience for me was how patients accepted, and we accepted the connection through telemedicine, even in cases in which the only option was phone, not video phone, but was good enough to take care of our patients. So this is a valuable lesson for us, and I hope will be part of our standard way of proceeding for the future.
Dr. Kanesvaran, I know that this was not the first pandemic in Singapore, so maybe you have more experience. What is your take on that?
Yeah, so you rightly pointed out, Philippe, and I just want to add on to whatever has been said by Dr. Garrido and Sobrero. So we had the experience of SARS in 2003. So in a great sense, we were quite prepared, and we were quite near the epicenter of China. So we were one of the earliest countries to get cases in the world. So in fact, we escalated our level of care to the second highest level at the end, early February. So that was quite early. So we were fortunate, although we have at this point about 43,000 cases for a small country of 5 million, but the number of deaths have been very low. And in terms of cancer patients with COVID, actually the numbers were very, very small because we started doing a lot of checks outside of the cancer center to prevent cases from coming in. As far as we know right now, there's no healthcare worker who has got from the cancer center who has COVID as well. So that way we've been quite protected. But to specifically answer your question about whether this is back to normal, the answer is no. It is the new normal, as you mentioned. So we have now permanently put a lot of things in place which were never there before. So patients are screened very thoroughly before coming in, and even the dwell time, the amount of time the patients spend in the center has changed. To some extent, we've kind of taken advantage of this crisis to make our systems a bit more efficient. So the wait time for patient has reduced. We do not want them to hang around too long. So they see the doctor, they leave the hospital, medication is delivered to their homes. So there's no dwell time outside the pharmacy as well. In terms of chemotherapy time also, we've kind of organized it in such a way that they don't wait too long outside. They're also not allowed to bring too many family members in. So this reduces the crowd as well. Telemedicine, we are just embarking on it. But I just want to say, while it's a good thing, we also need to be cautious about some of the problems that telemedicine can bring. Legal issues, for example. We can't use telemedicine for all consults because at some point you need to examine the patient and give them appropriate advice. So it has to be a right balance, but it's definitely a great tool to use in order to cut down patients' visits to the hospital in order to reduce their infection. So things have stabilized here. Our numbers have also fallen. We have opened up. People can go out to restaurants and all, but we are still very, very cautious. And I think until the whole world is out of it, all of us together have to be extremely cautious in keeping the disease under control.
Thank you. Dr. Trill, I know it was also a challenge for a psycho-oncologist. So how is the new normal today?
Well, first of all, thank you for inviting me to be part of this expert panel. I'm still trying to define what the new normal is myself. I don't think we are back to any kind of normal yet. I think that patients did understand the rationale for not being followed up so closely, but still we find some patients that are still very frightened about the possibility of not having received the proper cancer treatment during the acute phase of the pandemic. We still find many that are afraid of coming out of the isolation because the fears of contracting the virus persist, and the hospital has become now a place where they don't feel as safe as they used to be. It's a place where they can contract the virus for many of them. We also find patients that have cancer symptoms or cancer treatment side effects that fear that some of their symptoms may be due to the virus and persistently ask questions to themselves as well as to their doctors about whether they may have contracted COVID-19. Some are in a kind of a state of hypervigilance. And also, I think that now that the acute phase of the pandemic is being set aside, fortunately, I think that many healthcare staff are now starting also to experience lows, feelings of depression, sadness, anxiety that were not able to arise during the acute phase of the pandemic. Questions of how they have conducted themselves during this crisis are more present now. And there seems to be like an increased awareness of what could have happened to them. Before they were like exclusively focused on patient care and patients, and now they have like more psychological space to be more aware of the impact the pandemic is having on them or has had on them. And regarding opportunities, I think that there are a lot of opportunities have arisen from this pandemic. First, what has already been mentioned, the use of telemedicine, which is absolutely wonderful for patients, also for patients that are not well enough to leave their home to go to the hospital due to their cancer symptoms. But I think that also we need to be aware that not everybody in the world has access to a computer or to the internet. So this may increase the inequities in cancer treatment. I think that we need to find innovative ways to reach out to everybody in these situations. I think that another opportunity has been it has made us more aware of the patients and the staff's psychological needs. And I think we have been able to identify areas where there is an enormous lack of resources, lack of support for doctors, lack of support for nurses working under extreme conditions, lack of sufficient psychological and psychiatric support for patients, because the focus has been on COVID, or at least that's how patients feel, and an enormous lack of communication skills in staff. And I think that all of these are areas for improvement.
Thank you. Now, you've spoken about the lack of resources, but also other healthcare professionals such as nurses. So maybe Dr. Charalambous, can you give us your take about your profession and how are we dealing with this new normality?
Thank you so much. I absolutely agree to what has been already said by my colleagues on the panel. Definitely the nursing workforce was one of the healthcare professionals that endure much of the impact of COVID-19. What we experienced in clinical practice was nurses being shifted from one ward to another in order to prioritize the management of the COVID crisis. But moving on from the challenges, we also saw many opportunities for further development. For example, we have seen that altered caring pathways work much better, and they were much better received from the patients. And also we have identified and we have come across the real value of improved self-care at these times of crisis. So much more resources and effort needs to be allocated to patients themselves in order to be able to maintain their own self-care, of course, to a certain point. And of course, raising patient awareness, telemonitoring, as it has already been mentioned, they're all areas where they can be seen as opportunities that have arisen from this COVID-19 epidemic. And the final comment, it's we shouldn't be caring, we shouldn't be forgetting the care for the carer, because as previously has been said by Professor Trill, if you don't care for your workforce, then the resilience of the workforce will fade very quickly, and you will be exposed to the second and third waves of the epidemic. Thank you.
Thank you. Now, Dr. Sobrero, on the same topic, you've already spoken about treating differently the patients and how to apply care. Do you think that there is an opportunity to see if our de-escalation in medical oncology is the way for the future? Can we already assess these effects?
I think the great opportunities for telemedicine and teleconsulting, but I see a problem with that. And the main problem lies in the nature of the disease we take care of. If you take the average diabetic patient, he knows more or less what we doctors know. He's absolutely profoundly informed about everything of his disease. If you come to the arena of the cancer management and knowledge, well, our patients are not so deeply informed about what's happening to them. The goal of treatment most of the time is not so clear. So to them, that in my experience. So the sine qua non for telemedicine to take off and providing an opportunity for us to simplify things and to be prepared for future potential pandemics is to empower patients. At major international meetings, we have two mantras. One is precision medicine, and the other is patient empowerment. I'm not so sure that we are so good in pursuing the second of this. And this would be key to telemedicine, teleconsulting, and all the gadgets that are being developed by Facebook, Amazon, Google. You know, there is a lot of interest by these big companies into the market of health. And we should take advantage of this, of technology. But again, without forgetting the major obstacle to this, and that is more knowledgeable patients.
Now, many of, well, most of the countries are now starting to ease the lockdown. Activity is starting again. Still talk about a possible second wave of COVID-19 infections, maybe even a third or fourth wave, or something that becomes seasonal. So I would like to ask also the same questions to the members of this esteemed panel. So how should we prepare for the next waves? So do we need to redo the same things we did for the first wave? And will knowledge gained so far during this crisis will help our cancer patients face the second crisis? We know a lot of patients were scared to come to the hospital where they can catch the infection. So maybe I can start this time by Dr. Charalambous.
Definitely, some of the countries around the world, they're already experiencing the second wave, sort of, or local exacerbations of the epidemic. What we should be saying here is that it similarizes with the black swan problem. Of course, it's going to be the same virus, but we don't know if it's going to be behaving in the same way. However, having said that, we do have attained very valuable knowledge in terms of how to best manage this epidemic. For example, the personal protective equipment shortage that we have seen during the pandemic, we shouldn't be seeing something similar if the second wave is here. We need to be preparing for a better staffing, especially when it comes to the nurses who were on their majority at the front line of managing the epidemic, but also not only in numbers, but we have to be aware that it needs to also be a good skill mix. Need more experience and more expertise nurses in dealing with this epidemic if a second wave does occur. Of course, we need to be preparing our staff, as Professor Trill said earlier, about the psychological impact of these second waves, and also our patients. So we have gained a lot of knowledge, but we need to be placing this knowledge in a new context in order not to be distorting the way that cancer care is being delivered, because COVID, it's only on top of cancer because the patient remains a cancer patient.
Dr. Garrido, we've seen that patients with lung cancer or lung metastasis were maybe more vulnerable to this pandemic. So how to prepare for a possible second wave? What would you do differently in the organization?
Yeah, I could say, as has been previously mentioned, that safety could be a key point to act differently in terms of protection, but also maybe in terms of the access to tests for physicians and also for patients, serological tests and PCR, because it's important to understand in which situation you are or your patient are, no, in terms of making decisions. I also think that could be important if we have time to prepare, for instance, thinking about a split in hospital, because if you are able to maintain some hospital free of COVID, it means that you can continue with surgery or radiotherapy or other things that in this past pandemic we couldn't act in that way. So if we have time, we need to prepare which way we are going to organize our local options with the idea of a split in hospital if possible. I also say that this is time to build the evidence to support the next wave of guidelines. I think that societies, local societies, but also international societies, and ESMO for sure, make a huge effort providing us guidelines to help us how to manage this situation. But it's true that the level of evidence behind some of the recommendations could be improved. So it's time to do that in order to be sure that for the future we are covered in terms of legal issues, as has been already mentioned. Finally, the third point I wanted to highlight that we need a long-term vision, and we have to preserve research and clinical trial. And this is a situation that could be learned from the past in terms of maybe act, I don't know if differently, but to be prepared, because for the long term, we need result of clinical trials. So we need to take into account this point.
Thank you, Dr. Garrido. Dr. Kanesvaran, on the same topic.
So I echo what has been said already. I think we were quite fortunate here in Singapore that we didn't get hit by a very big wave as far as cancer patients are concerned. So we're going to maintain that. And to answer your question about how this has changed, I think, like has been mentioned before, has given us a lot of opportunity to change measures that can actually make patient care more efficient. But in principle, the key thing is to protect the patient and to protect the staff, to make sure that, you know, they are not exposed to COVID, and in the process also ensure that they get good delivery of cancer care. So I think Dr. Garrido brought up an important point about clinical trials. So when we first went into lockdown, one of the first things that was deprioritized was clinical trials. We had to close down clinical trials and ensure we delivered only essential services. But, you know, on the other hand, if you look at it, clinical trials are a key component of cancer care, and we can't just remove it just like that. Some are, you know, very important phase 3 trials where patients get access to drugs which they wouldn't have got access to because of either cost or otherwise, even for standard of care. So I think what has happened has taught us a lot of valuable lessons. The second point also to highlight what Dr. Garrido mentioned is about the evidence base. I think in a very short period of time, there were so many guidelines. Every known society, medical society to mankind had come up with guidelines within 3 or 4 weeks of the various lockdowns, either because there were a lot of people with a lot of free time and they found an opportunity to publish very easily. They came up with a lot of guidelines, but a lot of it actually said the same things and were not evidence-based, or they were not evidence-driven. So what ESMO is doing, some of the big reputed societies are doing, is building that evidence base, and that's what's lacking right now. And I think moving forward, that's what we need. We need all the evidence of outcomes, just like what you mentioned, Philippe. What do we know about all these measures, or what are the good measures that we should take? We don't really know exactly what has happened to patients who didn't turn up because of COVID, and now their diagnosis is delayed. We know that the number of diagnoses has dropped, you know, but that's because they didn't turn up. But how does this impact their clinical outcome 3 months, 6 months, 1 year down the road? And once we know that, that's when we can inform what the guidelines should be and should say. So I think that's where we are right now.
Dr. Trill, would you prepare differently? And do you think that we will be able to help our cancer patients better, our patients with cancer better, if we face a second crisis?
Well, I do hope so. I think that we need to focus on the areas with limited resources that I just mentioned, and we need to prioritize patients' emotional needs and provide psychological support to the cancer patient across the disease continuum, from the early symptoms of the disease and diagnosis until end of life or survival. I think we need to develop new ways of identifying the patient's distress, because we use the distress thermometer, which is widely used, throughout the whole world. But because the patients have not been able to go to the hospital as frequently as before, so distress has not been measured as frequently. And it is important because it allows us to identify those patients that are in most need of receiving psychosocial care. I think that we also need to teach simple psychological interventions to staff so that they can feel efficient in reducing some of the patient's anxiety or anguish when the patient is alone with the doctor or with the nurse. And regarding staff, I think that the staff is going to be psychologically better prepared to face a second crisis, because they will have more realistic expectations of what may happen, and therefore when we know what to expect, at least in part, that will decrease our feelings of helplessness. And if we can anticipate, even if it's a little bit, then we will have a greater perception of control over the situation that we're confronting, and therefore less feelings of impotence. However, I also think that more psychological support and resources to deal with the emotional impact of the pandemic on the medical and nursing staff should be made available to them, and definitely more training in specific communication skills when working under extreme conditions with patients in extreme medical and psychological situations that we have found are necessary. I think we need to provide more space to grieve. We have had, I think, the largest or one of the largest numbers of medical staff that have been infected and that have died of the virus in the world. And their doctors and nurses have not had time to grieve for their own losses of We need to provide guidelines to handle all the issues that arise, how to cope with the dying patient, burnout prevention, and the threat of being infected and of infecting their loved ones will still be there if there is a second crisis. So we need to provide them with coping strategies and develop solid evidence-based guidelines of psychosocial care to help patients, families, and medical staff as well.
Dr. Sobrero, so you think we have gained some reflexes that will allow us to better face the second crisis?
From the clinical practice viewpoint, say healthcare, I think we should count more on an alliance with family doctors. We tend to concentrate our patients at our cancer centers, mostly due also to the fact that the patient wants that, and on top of that, that the family doctor is really so little prepared to face the major problems that this disease produce. In my experience, quite a few family doctors don't know the difference between the advanced setting, the palliative setting, and the adjuvant setting. So we should really look for an alliance with them, maybe spending more time in trying to connect, to better connect with them. We need the help of the territory under condition of stress. From the clinical research viewpoint, I think that it should be our mandate to be more critical in the selection of very relevant clinical trials and not pursue the fine-tuning type of trials addressing questions that are not so relevant. So to reduce the number of additional tests and burden posed on the patient.
Now, Dr. Sobrero, thank you. You've spoken about collaboration and the alliance, for example, with family doctors. As we know it, oncology is a multidisciplinary field with a lot of collaboration between different departments. So we are lucky to have on this panel different experts from different departments. So I would like to hear your views on the value of collaboration, on integrating different perspectives. So this would be the clinician, the cancer nurse, and the psycho-oncologist. So maybe we can start with Dr. Kanesvaran.
That's an excellent question. I think collaboration has improved. I think in this time of crisis, everyone realizes the importance of each other's role in communicating. And through this communication, all of us are able to work better together in preventing firstly, COVID from affecting our patients and our staff. And we actually try to think out of the box of new solutions, new ideas. All this while we've used to a very fixed kind of system of medical care. Patient comes in, sees the doctor, the nurse will assist the patient. After that, goes and get a prescription, goes and gets their chemotherapy, then leaves the center. But now we are in a situation where we don't want patient to be exposed too long to a medical center. So we are forced to think of ways of trying to minimize that. And you'll be surprised, but the nursing staff, the allied health services, they all have wonderful ideas, but sometimes we've not just sit there and listen to them because everyone's just busy doing their respective roles. So I think for the first time, because it's a crisis situation, all segments of medical care, healthcare professionals are, I think, truly working together for the first time, like truly sitting down and giving each other the due respect and recognition for their ideas and listening. And I think this has done wonderful things to our medical care and system. At least in Singapore, I now know all of them a lot better. We all work together in teams, trying to do safe distancing, making sure patients are, a sufficient distance apart when they're sitting down, when they're waiting for appointments, trying to explain some of these concepts to them about chemotherapy, and why, certain therapies, maybe we should use oral, especially if the effectiveness is about the same. The pharmacy staff are becoming like, are able to dispatch medications through courier service without having to see the patient, but give them advice via phone or, telemedicine. So I think it has further enforced the importance of collaboration.
Dr. Charalambous, so in our hospital, for example, we know that departments such as the hygiene department and the nursing department were leaders in organizing the pathways and cancer care. So how do you see this collaboration and its evolution?
Cancer, as you may all well know, it's by itself complex enough. The COVID pandemic came and made that management of cancer and cancer patients even more complex. As you said, cancer care is based on a multidisciplinary pathway, at least in most countries around the world. And what the pandemic did is that it brought the multidisciplinary teams closer together. I think for the first time, every member of the multidisciplinary team was participating in this team on equal terms in terms of the knowledge they had in relation to the problem at hand. So it made the collaboration much more demanded by the circumstances at hand, and we have seen very innovative and novel ideas that came up through these multidisciplinary teams. And just recently in May, a paper came out coming from the UK, and in fact, during the pandemic crisis, the outbreak, many hospitals introduced the virtual multidisciplinary meetings, which in a way also contributed to the management of the pandemic, and in a way they managed for the continuation of the care of the cancer patients. So this was, in my opinion, one of the most valuable opportunities that rose up in terms of new ways of collaborating and making care more efficient and more effective for our patients within a context that it's safer for the patient and for the care themselves.
Thank you, Andreas. Dr. Trill, your take on that, on collaboration and its evolution in the field of cancer?
Well, I think that the need for working together has become very evident now during this crisis, and as well as the need to take into account the patient's psychological makeup. In addition, we also have scientific evidence that psychosocial interventions are effective in reducing anxiety, depression, and emotional distress in our cancer patients, and they improve adherence to treatment, which may impact on treatment outcomes. They improve treatment-related side effects and improve quality of life, among other things. So I think there's no question that psychosocial care should be integrated into the mainstream of care of the cancer patient. During the pandemic, psychosocial intervention, I think, has been able to address many very important issues, such as patients' fears, helping them to deal with the uncertainty, helping reduce the feelings of loneliness. I think we have also been instrumental in helping families coping with the situations and to better equip the medical teams with some simple resources to confront the difficult medical and emotional situations that have arisen during the pandemic. And I think that there has been a certain relief among staff that we were able to help in some way with the emotional burden of care. According to the International Psycho-Oncology Society Standards of Quality Cancer Care, we have 3 standards of care. One is that psychosocial care should be recognized as a universal human right. The second one is that quality cancer care must integrate the psychosocial domain into routine care. And the third and last one is that distress should be measured as the 6th vital sign after temperature, blood pressure, pulse, respiratory rate, and pain. And I'm proud to say that we have had over 70 cancer associations, scientific societies, organizations around the world endorsing our standards of quality cancer care. So I think that's just the way to go.
Thank you. Collaboration was the last topic of this roundtable. I would like to thank you all. So it was a very good discussion. We've shown that some of the things that we implemented during this pandemic are here to stay. So we can say that we have a new normality, that you are all proponents of implementing things such as telemedicine. And I've heard that there are also some privacy issues we need to tackle, but also some issues related to the nature of cancer. We've seen that it is important not to leave behind topics such as cancer screening and clinical trials, because they are very important in oncology. We've learned about facing the acute phase, and we have strategies for facing the second wave. We know now that PPE is very important. We have guidelines. We should probably test our patients beforehand. And finally, we've discussed multidisciplinarity that is key in oncology, but also in facing this pandemic. So with that, I would like to thank you all for your participation and see you soon.
Thank you.
Thank you.
Thank you, Philip. Thank you, everyone.
Thank
Nice to meet
you.
everyone.